to listen to them, and then thereafter the Minister. Thank you.
Very much, Honorable Dr. Thembekwayo. Honorable members, we now only have 2 hours with the Northern Cape. I would wish that we interact with them immediately, but we'll always traditionally, just to give the space to the media, give them to go through the presentation quickly. Honorable members, we would not really want to do details slide by slide because the presentation has been with us. But let me formally welcome you and hand over to our secretary to indicate the presence of members here, and then she will also deal with the apologies before I invite Northern Cape to start the presentation. Ms. Machalamba.
Good morning and thank you, Chair. Present is Dr. Dlomo, Ms. Geller, Mr. Sokacha, Dr. Jacobs, Ms. Seke, Ms. Kwahube, Ms. Wilson, Ms. Ishmael, Dr. Thembekwayo, Ms. Chirwa, Ms. Hlengwa, Mr. Van Staden, and Mr. Imam Sheikh. Thank you, Chair.
Okay. Thank you very much, honorable members, for logging in. We will then start with our meeting, with the next item. Honorable members, leadership from the Northern Cape, I just see here Northern Cape HOD co-host. Honorable members, we now only have 2 hours with the Northern Cape. I wish that, but we always normally start with the MEC, see your face, MEC, and then you welcome and you tell us who's accompanying you. Always traditionally you start in whatever way, whether you start or the HOD starts. Give them to go like we are to thank you. The presentation has been with us for some hours now. The presentation is not completely unfamiliar, so we will appreciate you to go a bit faster on it because it's members here who still want to engage you on the presentation that we have prepared. Honorable MEC, can I give this space to you now? Honorable members.
No, thank you very much, the Chair of the Portfolio Committee of Health, Dr. Dlomo. Let me take this opportunity to really welcome all honorable members of the Portfolio Committee. I've listened to you attentively in terms of your time pressures that you only give us 2 hours. And our presentations are a bit bulky, but we'll try to gallop over it. I'm accompanied with the HOD, acting HOD, Dr. Deontes, with senior managers. There's a team which is with, but he'll be the one who will be doing the presentation. So thank you for this opportunity, Honorable Chair. And then we will then gallop over the presentation and allow at least for some engagement so that we must be in a position to respond. So with the permission, Honorable Chair, can I give over to Dr. Tace to then lead us with the presentation? Thank you very much.
Thank you, MEC. Thank you, Honorable Chair and the honorable members. It gives me great pleasure and opportunity to present the work we've been doing since the first wave right into where we are now in the second wave. Can you note the slides?
Dr. Tace, are we able to see? Okay. Now, Honorable Dr. Tace, how long is your presentation? Let's start there. How long is it?
Chair, it's a bit bulky, but I can congest everything into 20 minutes, Chair.
Please, that would be excellent. 20 minutes. Thank you.
Thank you, Chairperson. That's right. Once again, good morning, Chair and honorable members. The information in this slide is already known. Suffice to say that in the Northern Cape, we confirmed our first case on the 25th of March last year, and it was as a result of a church gathering in Polokwane local municipality area, a church gathering in the Free State in Bloemfontein, where the virus was then imported to us. And then our first death was reported on the 11th of May. Next slide. Chair, we know the procedures by now, the NPIs, non-pharmaceutical interventions that we should use to guard against transmission interpersonal transmission. The first wave, Chair, saw us rising very sharply up the wave by week 27. There were in total 1,552 cases per week, ending the 2nd of July. If you see week 22 up until week 30, Chair, we rose from an average of 88 to 1,552 within that period. And by September, ending September the 20th, we also had the highest peak during the first wave at 1,644. Next slide. Where we are at now, Chair, the figure on the right, the red graph, honorable members will see the peak there, the number depicting at the crest of the peak is 1,898. Now that figure outstripped the highest peak in the first wave, and it contributed only within 2 weeks. First 2 weeks of January. The second wave started the week ending the 12th of December, followed by a rapid surge, which arose to that 1,898. But gladly, by the week ending the 6th of February, the peak started to subside very drastically, and the number of new cases dropped back to 614. Next slide. This depicts just the trajectory of the first wave into the second wave, Chair. I think we talked about the peaks of the first and the second wave combined. I think we can let this one go. And in this slide, Chair, is just the disaggregation per district. And I want honorable members to say just the outliner there, the outlier being Namakwa district, the deep blue curve. Chair, you will see it's a total outlier. By the week ending the 17th of Jan, we had a huge, absolute huge surge. And that contributing factors included the travelers. It's actually a traveling transmission issue. Chair, as you may recall, our district in Namakwa is a corridor between the Western Cape and Namibia. So all of the cases contributed there was really through traveling. And secondly, there's some industry also there, the mining, emerging mining and solar power industry. And by the time people settled at these industries, the numbers then dropped sharply. Next slide. Chair, the stats by districts, as we can see, Francis Bard still leading at the total positives of 10,976, then followed by Pixley Kaseme contributing to 90 cases per 100,000. We then had ZF, the area of Uppington, at 609 positives, contributing to 109 cases per 100,000. Next slide. This is just a week-on-week variation, Chair. I think we can let this one go because the previous slide also talks to it. And what's important, Chair, just to spend one extra minute on this slide, because this slide depicts the gravity and the clinical importance of how the virus affected the population, citizens in the Northern Cape. Now, there are three issues, Chair, that normally we use to track the gravity of any pandemic or viral outbreak. The first one is your hospitalizations. The second one is your clinically deepened infections, which means where you need ICU. And thirdly is your positivity rate. Now, these two is the top line. If Chair can see on the red curve, by 20th December, it rose very sharply to 178 admissions, which was the highest ever. The 49 number corresponds to just before the level 3 lockdown that the president announced, and the tapering off is where the numbers dropped because people were now under very stricter conditions, including ICU admissions, which was highest, was 36 by the week ending the 17th of January. Very significant, Chairperson, because these two graphs actually coincide. There's a synergy between the number or total admissions and the ICU admissions. Next slide. Chair, this one just depicts the public and private total admissions, the ICU as compared to ventilated in ICU. We can also see, Chair, as the weeks went on, we started 24th of Jan 161. By the 7th of Feb, it has dropped to 124. If we look at ventilated patients in ICU, also a drastic change from 22 right down to 8, which actually means that we managed to ride this wave very comfortably through what we have prepared the ground for. Next slide. Chair, this slide can also go because it just depicts the number of deaths that in 1 month, January 2021, just a month ago, the 2 weeks where the highest peak was, we experienced 137 deaths. Not the entire month, only for the first 2 weeks. Next slide. Chair, we all know that the comorbidities of hypertension and diabetes contribute immensely to the outcomes of our patients. And we can also see that most of the mortalities is as we experienced it, still diabetes and hypertension taking preponderance. And in this case, for the first time, we've seen in the first wave that the infections affected females more, but the males succumbed to the virus. We've since seen the emergence